Well, hello, everybody. Welcome to another episode of HeartBrief. This is Joel Kahn, medical doctor, triple board certified cardiologist, university professor, and director of a preventive cardiology clinic in Detroit in southeastern Florida. Let's get to three very interesting articles this week that I made an impact on my patient care and perhaps will make an impact on yours too, as well as your own health. Doctors need to stay healthy too, all right? So the first article is absolutely fascinating in MedCom, published by Wiley, just released in the last couple of weeks. Lipoprotein A, ABO blood types, and clinical outcomes. Novel findings and clinical implications in patients with chronic coronary syndrome, or CCS. And they gave some background. Why would they ask a question about blood types, lipoprotein A, and outcome? And there actually is some data that non-O blood types in people with coronary disease may predict higher risk of adverse outcomes. So they asked the question, how does that interplay with the presence or absence of genetically inherited lipoprotein A cholesterol? And they had quite a large study. They had the exploratory cohort of 7,611 persons who had, over the course of 55 months, 560 major adverse cardiac events, heart attack, strokes, bypass, death. They knew their lipoprotein A and they knew their blood type, and they generated the hypothesis. Then they applied that to 7,916 members of a cohort called the confirmatory cohort. And as expected, the higher the lipoprotein A, the more events were seen. But the non-O blood type patients had a higher risk of events independently. And then they looked at the interplay between lipoprotein A and non-O blood type, and they found that they were additive even after figuring in other factors like diabetes, smoking, hypertension. I'll read you their final words. In conclusion, our data demonstrated for the first time a more prominent association between lipoprotein a and adverse outcomes in chronic coronary syndrome patients with non-O blood type compared to those with blood group O, suggesting that ABO blood group measurement may be clinically useful for decision making and lipoprotein a intervention. And I agree. I find most patients don't know their blood type. Some of them ask to get it done in the clinic. In general, nothing related to this brand new paper. This is the first time this association with lipoprotein A has been reported. There are previous papers about non-O blood type and coronary disease outcome in general, and many theories. So now, perhaps to better risk stratify our patients, we should certainly measure their lipoprotein A genetic cholesterol routinely. And secondly, we may think about getting their blood type and giving them the information to deal with managing their risk optimally as much as possible. Of course, we still don't have an FDA-approved drug for lipoprotein A. All right, next paper. You ready? Heart brief. American Journal of Preventive Cardiology within the last 4 weeks. The importance of life's essential 8 in predicting short and long-term incidence of cardiovascular disease. The atherosclerosis risk and community study. That is known as ARIC, A-R-I-C, a United States database. And it is a large database that looks over time at the development of coronary events in people without known heart disease. I have it up on the screen. Life's Essential 8 is an American Heart Association construct that took over from Life's Simple 7 because they added sleep duration and quality to the equation. And you can see here it's a gauge of physical activity, diet quality, sleep quality, nicotine exposure, BMI, blood lipids, blood pressure, and blood glucose. And it has been shown over and over now that this simple construct, Life's Essential 8, anybody can go online and quickly determine how they score on these 8 factors and work to improve them. Very, very simple. But many studies now have shown that this simple scoring system is proving to be predictive of many things. And in this study, in the ARIC database, looking at cardiovascular outcome, they again showed that of the 8,083 participants who over time, 4% developed a new diagnosis of coronary heart disease, 2% developed a stroke, 0.3% developed new atrial fibrillation. The lysosensylate was negatively associated with developing these diseases. That is, those that were the poorest adherer to these 8 factors had more heart events that came out. Those who were the most adherent had the least events. So their conclusion, a higher lysosensylate score is consistently associated with a lower probability of the incidence of coronary heart disease during both short and long-term follow-up. They actually were able to predict, since the ARIC database is not new, the possibility of developing cardiac events all the way out to 25 years, because that's what's available in the ARIC database. So quite a simple program to refer your patient, to have brochures from the American Heart Association or handouts on lysosensylate, have them focus on those 8 big topics. I have to get on a webinar in a little bit and talk to some investment people about how they can add 20 years to their lifespan. And I'm going to actually start with lysosensylate as a good construct that in similar studies has been shown to potentially add 12 to 14 years to lifespan. Now I got to get them up to 20, but we'll talk about that with that group. So interesting paper, and I think we should be talking a lot about lysosensylate as much as possible. And the third paper that I want to bring you today at HeartBrief is about one of my favorite topics, which is who needs a coronary artery calcium score and why does it matter? A test that's now 35 years old and is still grossly underutilized, in my opinion. So from American Journal of Preventive Cardiology, the utility of coronary artery calcium scoring in low-risk patients, the multi-ethnic study of atherosclerosis, or MESA. Some very big names here like Michael Blaha, preventive cardiologist at Johns Hopkins University. And they, of course, went to a database, in this case, MESA, very famous database with 6,712 participants. No heart disease at the beginning, but many measurements that were made. They could calculate their 10-year risk of atherosclerotic cardiovascular disease. They could use the new American Heart Association prevent equation to calculate 10 and sometimes 30-year risk of cardiovascular disease. And they looked in this group, average age 62 years, half of them were women, at the development of first, cardiac events over time. And they looked at it with and without calcium scoring data over 17 years. And what they found was that, and I'm reading here, the coronary artery calcium score was most strongly associated with increased atherosclerotic cardiovascular disease risk in low and borderline risk individuals. Among those individuals, addition of the coronary artery calcium aggregation score to the other calculations improved accuracy and improved prediction who might be statin eligible. So it says right there, using a statin eligibility threshold of 7.5%. The addition of coronary artery calcium scoring correctly reclassified a net of 10% of the low borderline risk individuals overall. And in the prevent analysis, it was actually 17%. So a simple, roughly $100, 15-second calcium scan with a 0 score or above 0 score can cause nearly 1 in 5 people, or roughly, to be reclassified for the need or the absence of a need for a statin. Of course, there are guideline recommendations that people with a coronary artery calcium score of 0 generally do not need and may not benefit from a statin and should focus on lifestyle. So I am still dismayed after 35 years and in my own practice, 30 years of scheduling coronary artery calcium scores, how few are done in the primary care world and even in the cardiology world. Maybe this article will help you here at HeartBrief to reconsider your own use of this very simple, widely available, and safe test. So that's the end of HeartBrief this week. 3 very interesting articles. Thank you, and we'll be back with more interesting, new, and novel medical findings in the next episode.